Good evening, everybody, and welcome. So it's a pleasure for me to be hosting this webinar on behalf of the Faculty of Dental Surgery at the Royal College Surgeons of England. My name is Andrew Eder. I'm an FDS board member and have had a real interest in toothwear and toothwear management over the last 25 years. So it's a particular pleasure for me this evening to welcome Professor Bas Luemens. We have met really over the last year as we've been contributing both to the new toothwear book, which will be around shortly, but that's when we met a few months ago. And so I was excited and delighted to be able to welcome Bas to give the next of our webinars. So just a little bit by way of background, Bas is Professor of Oral Function and Restorative Dentistry at the Radboud Medical Center in the Netherlands. He is the lead author of publication Severe Toothwear, the European Consensus Statement on Management, which was published in 2017, and also the Management of Toothwear book with several co-authors in 2019. Bas heads up the Radboud Toothwear project, looking at severe toothwear management, and has also published widely and is in referral practice in the Netherlands. So without delay, I'm going to hand over to Professor Luemens in a moment. We are going to host this webinar for about 45 minutes or so. There will be a question box appear. Please do add any questions. And at the end of the 45 minutes, we will go through and cover some of those, and we will bring everything together at about 7 o'clock. So without further ado, Professor Luemens, over to you, and thank you for joining us.
Thank you very much for the very kind introduction, Professor Eder, sorry. Yeah, Andrew, thank you very much. I cannot add a lot extra. The title of the presentation is today the management of severe toothwear, and then especially high failure due to high risk. That meaning that I would like to take you along with me in the insight we have in the last 12 years, having the project going on. Is it possible to predict and see the risk factors in those patients also, if you're going to start restorative treatment, to think about the risk factors? So that's the main important goal of today. I'm coming from the Netherlands. Of course, it's a very small country. And then in Nijmegen, that's exactly on the opposite side of Amsterdam and the eastern border to Germany. And it's in fact also the eldest city of the Netherlands, more than 2,000 years old. We're the Romans, and it's a beautiful city. What's over of that, because all the old buildings are destroyed, and it's a beautiful city. And of course, I would like to show you our dental school 5 years ago, fully renovated, and I think it is incredibly good equipped with all the things we need for this dental school as well as for the research. The content of the presentation, what I already told you is I would like to go into the diagnostics, the etiology of toothwear. An option is counseling and monitoring. I think it's a very important point, so I'd like to stick to that. And also the restorative treatment options, minimal invasive. And I would like to show you some cases of localized toothwear, generalized toothwear, using several different techniques based on minimal invasive, what we are conducting in Nijmegen, and show you also some survival data of publications which are now already available. And the goal of today, of this evening, is to give you an insight of an overview of relevant risk factors in the treatment of toothwear. That's my main goal, so that tomorrow, if you're treating patients, you think, hey, this is interesting. I have heard it yesterday. That would be my goal. So 12 years ago, we started the Radboud Toothwear project in Nijmegen. From scratch, we didn't have anything, only some patients. And then from that point on, we now have included more than 200 patients, these kind of patients, so with really moderate and also very severe toothwear from all kind of etiological factors. So bruxist, erosive patients, etc. Everything is included. And you mostly will see beautiful arches, because that's one of the inclusion criteria. Other patients also need to be treated, but in the project, in the research project, we needed some cutoff points, and therefore we've chosen for full arches to reduce the amount of variables. The goals of the project are to determine the risk factors causing the disbalance between intraoral attack and defense. So it's a balance between what's happening and what can we do against it in the mouth. To ensure an optimal and personalized management. So what does the patient need when they have tooth wear? And we don't want a concept which fits everybody. Counseling and monitoring versus restorative intervention. When to go for counseling and monitoring, when to go for restorative intervention. I would like to take you along with that. And also to improve and preserve an acceptable level of oral health related quality of life. And the final one of that last point is the oral health related quality of life. I think that's one of the most important things, because you can talk about how long are the restoration lasting, 5 years, 10 years, or 11 years whatsoever. But in these patients, they have a problem. You would like to help those patients. And then I think the best outcome is the patient itself. So the oral health related quality of life. And I think it's much more important to show data from that side than only on outcome of restorations. And the philosophy of our group is conservative. Don't make it more complicated than it is, because it is already a huge job. Be pragmatic, personalized, and based on minimum invasive interventions. And that can also be indirect. I don't know what's this happening. Removed. Yeah, it's gone. So the diagnostics and etiology. I have to say it is multifactorial. Perhaps you know, but I will state it another 20 times, because you can say about this patient it is erosion, and I see attrition, and I see abrasion. But then you already give a diagnosis, and in fact, if you say, hey, this is erosion, then you say that it is really based due to chemical wear. And I think this is what we have to abandon. We have to look at it from another way. So I would like to go down, not only directly going in the diagnosis of attrition, erosion, and abrasion, but go for a more overall view. Is it more chemical? Is it more mechanical? And what are the modifying factors in this patient? So looking at this patient again, then you could say, I see here raised restorations. I see a lot of tooth material lost. I see here also a raised restoration. I see wear on non-occlusal surfaces. Also a lot of wear on occluding articulation area. So I see NCCL. So just describe what you see and then think about how much is the part of chemical and how much is the part of mechanical. In this patient, I really wouldn't know what would be more the chemical or the mechanical. I know that there's always a combination between those two. So you have chemical processes, you have mechanical processes, and we also have some modifying factors. And I think the patients we are seeing today and what you see in your dental practice, it will never be only from one Coca-Cola a day too much, because then you won't get this amount of wear. You need other stuff, you need other origins, other factors. So the patients we are seeing, I think they are somewhere in the middle, but I don't know where. I know it's in the middle. So from chemical processes, think about everything what is acidic. Okay, what is acidic? Tomatoes, acidic fruits, reflux, the bulimia, of course, soft drinks, and everything what we think is fresh. Hey, this is nice fresh what I'm now drinking. No, it's not fresh. It's just acidic. Mechanical, of course, we know the patient with the huge masseters and like the Brux's type, the clenching and the grinding types. But not only the clenching and the grinding, also biting on pens, on nails, on wedding rings. After the wedding, it became much better, but still patients are biting on everything they know and they are not aware of it. So it's again, the patients have to become aware of what is happening. Then we also have some modifying factors, the amount of saliva, the sometimes huge chewing forces, like this patient with the bar on top of his eyes. The soft tissues, think about the tongue. The tongue is like leather. And abnormal drinking habits. Now, Andrew only gave me 45 minutes, so I have to reduce my presentation to some important aspects, in my opinion, which are perhaps not the most common ones where you would think about. So the reflux, the saliva, and abnormal drinking habits. And I think this is one of the most important slides of my presentation, because I would like to show and explain the role of erosion. And the role of erosion is that you have a piece of enamel, yeah. Then we put an acidic attack on top of the enamel, and per definition, you will lose a very small, but a layer of enamel, so it will dissolve. Each acidic attack will dissolve a small layer of enamel, and that is not repairable. Lost is lost. The layer beneath is softened, and that's still repairable. However, in the time it's still soft, it can be easily break down and worn down due to, for example, grinding or brushing. So then it's vulnerable for further loss. I think this is very important to understand, that the erosive factor, the erosion, will accelerate other types of tooth wear. I will come back to that later on. Going for the reflux. Reflux, everybody of you now has reflux. Please don't go to the doctor immediately. It's a normal physiological process. There is acidic gastric acid in your esophagus. It needs to be there. And due to peristaltic movements and buffering through saliva, let's say the acid stays down enough and it won't hurt you. However, if the pathological process appears, so it will get symptoms and there will be complications, then we are talking about gastroesophageal reflux disease. That's pathological. For example, heartburn or erosive tooth wear and all the symptoms which are linked to reflux. And looking back from all our patients which are now included in the project, I think that approximately 40%, and that's much more than I ever would have thought about, 40% of our patients have, let's say, not diagnosed reflux, because that's not true. They have symptoms of reflux. So they have sometimes heartburn, they have some regurgitation, or they have all the symptoms to what they have. And we never thought it would be that big important factor in the continuous erosive exposure, especially during the night. So in the day, I don't think that reflux for us as a dentist is important, especially the reflux in the night is of importance, because then we do not have that much saliva, and then the acid drops a little bit, not to 1.8, but let's say to 4, and that for a longer period of time. And each time a small layer of enamel is dissolved and also it's softened, and then the patients are clenching. And perhaps that is one of the main reasons of these patients. I like this publication very much from Rebecca Moises and Rupert Austin from King's in London, and it is a beautiful overview in the British Dental Journal in 2018, if I'm correct, where they describe the role of reflux and erosive tooth wear from a very simple and clear, understandable way. So I would like to invite you to read this publication again after this presentation. Besides the reflux, so it's a very interesting topic, but I can go on talking on that topic. So another important reason is in this patient. And again, what do you see? Not say erosion, not say attrition. What do you see is I see raised restorations. I see wear on the palatal side. I see an incredible amount of raised restorations. I see a very dull aspect of the enamel. I see very strange non-carrier cervical lesions. How is it possible that a 27-year-old woman has such amount of wear? And what's very typical, and perhaps it's because she's Dutch, is that she has 4 canines and 1 canine, and it's not, also in the Netherlands, not fully normal that you have 3 canines at a row. And also at the 3D scan, you can clearly see that the whole cusp, the palatal area of the premolar is just gone. And the difference between the left and the right side, it's incredible. So how is it possible? And I think one of the important factors in her mouth is saliva. Because if you look at the flow, and the flow is in her case 0.03, that's even 3 times less than hyposalivation, and let's say 15 times less than normal, or at least 10 times less than normal. And then the next step, that's the flow. So there's almost no saliva, no buffering. And then the saliva she has is 5.7 pH. And the lower the flow, also the lower the acidity. So if the patient has a very low flow rate, also the pH of the saliva is really low. And in her case, her saliva, which is to be protective, is almost erosive itself. So that's interesting. You cannot change it, you cannot change the flow, but you can do some protective measures or more covering of the teeth. Another one is the abnormal drinking habits, which is perhaps a little bit underestimated. And we always ask patients to, here's a glass of water, please drink it. We're not saying what we are going to look at. And I asked him, and of course he also agreed that I would show you this this video, is how he's drinking. Now, have a look. I'm ready? Yes, okay, so and this is the way he is drinking. Not for fun, not for my video. It's just the way how he does it. And this is with cola, this is with wine, this is with beer, this is with water. So the acid is going all the way around in his mouth. And so the exposure time is also much longer. And otherwise, if you would drink normal, the lip and the tongue are also protective. There's no protection because it's going everywhere. And he is even very proud of it. If you can see in his eyes, he's proud of what he did. Try to say to him, don't do it again. Perhaps he would listen, but it's very complicated to change the behavior of drinking. So I would say that the effect of swallowing and drinking habits are often very underestimated. And the hypothesis is what you drink is less important than how you drink. So after this webinar, you're going to drink whatever good glass of wine, and then you think about, okay, how am I swallowing? And then perhaps you also notice that what you're doing is a little bit similar to what he is doing, then please call me. So looking back at the reflux, what kind of advices and treatment options do you have? Now I'm going to go a little bit in the preventive advices. If the lifestyle changes, and especially avoid coffee, fat, unhealthy foods, orange juice, etc. So all the unhealthy stuff is really provoking reflux. We have some preventive measures, toothpastes and mouthwashes, which contain stannous fluoride or stannous chloride. And this solution gives a kind of a layer around the tooth, protecting the tooth from an erosive attack. So for example, before sleeping, take some mouthwash, and then it will give some protective measures. And also from Nadine Ganz and Nadine Schlüter from Germany, they also have done quite some in vitro studies, but also some clinical studies showing that using these materials, your teeth won't grow anymore, but that the protection and the progression of wear is less, and also the sensitivity of the wear is less, because sometimes patients complain about pain, and then in the meantime, before treatment, this could be a good option. And of course, medication, that's not up to us, in my opinion, that's up to the medical doctor. And the proton pump inhibitor, so the production of acid is then reduced. Omeprazole, pantoprazole, etc. And I think that's a very, especially for the diagnostics purposes, a very good one to give a patient 1 month proton pump inhibitor and just see what's happening. And sometimes if they really hurt from tooth pain, sensitive teeth, then giving them a proton pump inhibitor sometimes really reduce the pain in the mouth. In fact, very logic, because there's no acid exposure to the tooth anymore. Another preventive advice could be the placement of a night guard. It's a beautiful one, this, but okay, it's a he is using it. You can see clear facets. It's breaking down. And then the question is it really necessary to give all our patients night guards? I don't think so. On individual basis, perhaps yes. On general basis, everybody needs a night guard. No. Because, and this is a study from Andres Johansson, is the effect of a night guard is unclear, as there is no proof that it helps to prevent bruxism. 25% of the patients starts biting harder, 25% the bite force are reduced, and 50% is just similar. That's from bruxism point of view, but also from tooth wear point of view, there's no proof that it helps to reduce the progression of tooth wear over time. One of the things is there's a low compliance. Secondly, it's only during the night, and do you know what the patient is doing during the day? And finally, if there is a huge amount of reflux present in the mouth and the patient is misdiagnosed, and we think that it is we think it's the bruxism or the tooth grinding, then the diagnosis is wrong, and that's the problem. It is multifactorial, what I told you, and that makes also preventive advices very complicated. So just a mind changer, perhaps. And it's about preventive measures. So here you see a patient with clear mechanical wear, and then the question is it preferable to put a night guard in, so mechanical measures, or would it be more advisable to look at chemical measures and then think about the erosion, the accelerating process of erosion in the whole tooth wear process, that without now, if there would not have been a chemical exposure, mechanical features would not have occurred. So you see clear mechanical facets in this patient. And the question is, if there would not have been a chemical attack, would the mechanical feature then present itself? So isn't it that the chemical measures are more important than the mechanical measures? Think about it, please. So Andrew already told about the publication, what we did in 2017, the consensus paper, in which there was a flow chart, and for the age of the patient, the tooth wear is observed, the tooth wear observed physiological or pathological. Physiological, it's normal. All patients have more tooth wear. All people have more tooth wear than young people, and if that's the case, no problem. If the patient has pathological tooth wear, the wear is not fitting to the age of the patient, then have a look at the geological factors, the risk assessment documented in your file, and then continue. Then it's already a huge problem that from all our patients, I think the 200 patients, yeah, I'm not exaggerating, but I think that 50% of the patients at the start, when they come in, I really don't know the main reason why the wear occurred. Due to the multifactorial process, due to the role of erosion in the whole system. So it is more complicated than we often think. So as it is complicated, then it's a very interesting advice to just start counseling and monitoring. Counseling and monitoring means you give information to the patients. I see this, perhaps it could be this, or it could be that. Give them homework. Do you have reflux? Just listen to your body. And if there's no real concern, so if we would wait and we could do the same treatment if I could do now, then I would say just leave it as it is and stay in this circle. I will come back to that. If there's a problem, patient is in pain, yes, of course, then we have to do something, and then I will show you later on. So restorative interventions. So from the monitoring, and stay in the monitoring can be for 6 months, it can be for 12 years, because some patients had a period of the progression of tooth wear, and then afterwards it's physiological again. And we now also have in the study of 60 patients are in the monitoring group, and I think of them there are quite some which are now already more than 10 years in the program, and the amount of wear is not that huge difference between what they had at intake. For example, this patient at intake, yes, absolutely, there was a lot of wear on the palatal side and some cuppings, and there was no demand for treatment. So if there's no demand for treatment, I am not going to restore the patient restoratively, because then you are in problem. After 5 years, I saw him after 1 year, 3 years, 5 years. After 5 years, this was the situation. I did a subtraction, tooth level, and interestingly, is that at the baseline, I could see a cup on the occlusal surface of tooth 3-7. At 5 years afterwards, yeah, of course, it is a little bit bigger, but not, I expected it that it would be much bigger. And also on the palatal surfaces, the amount of tooth wear over time is not that much. So what you now can see is that tooth wear is not on the areas where I thought it would be, and I thought the progression would be. It is more now on the incisal edges and the occlusal surfaces, and especially on the right side. So the patient is really grinding to the right side. And perhaps you can make the conclusion, draw the conclusion that in the beginning, perhaps before the intake, it was more a chemical process over time, where now the chemical process is less and the patient is more mechanical. So it has been changed over time. So if there's no demand for treatment, stay in the counseling and monitoring. It's also a treatment. Often the progression of tooth wear is unknown, what I just showed you. You cannot predict how fast it will go in the future. We think we can do a lot, but we cannot do that. There are periods of activity, periods of inactivity, and if you do the monitoring, you can postpone a restorative treatment. And postpone means if you can postpone it for 10 years, one circle of restorative intervention is already gone. So you save one restorative intervention cycle. So to determine the progression of tooth wear over time, it increases the commitment for the restorative treatment, because often patients, they don't have a demand for treatment. So yeah, why should we do something? But if this patient sees, hey, over time, something is going on, the patient becomes problem owner, and in the end, shared decision making, you decide, not you decide, the patient decides, you will give information, and both of you then say, okay, what are we going to do? Some restorative options, and yes, I know I have to get a little bit fast over this different types of treatments, because it's not possible to go really into detail. I will just like to feed you with interesting treatments. If we have localized tooth wear, two options, dial appliance, two options in the dial appliance. The more known one, anterior dial, but also I would like to show you a posterior dial. And of course, you can use different treatment options. And honestly, I really don't care which kind of material, which kind of composite, if you're using composite or indirect composite or ceramic, if in the end, the indication is okay. And if the indication is okay, it doesn't matter what kind of material or what kind of technique you're using. If there's localized wear, I'm not going to treat those teeth which are not affected. So then I'm only treating these teeth which are affected. I would like to show you a case of anterior dial. A younger boy, 14 years old, before he had orthodontics, the dental hygiene was terrible. It was a shame of his teeth, and he had orthodontics before, and I saw him before the orthodontics. And then I asked the orthodontist, okay, please open the bite a bit, because now it's easy. And if you're finished, I can do the lengthening of the teeth, and now everybody's happy. Then at the end of the orthodontic treatment, mother became sick, patient was not coming to me, and 6 months later he came, then the bite was closed again. And I then the same day, okay, I cannot let him go in this way. He was a shame. And then I just, in the same day, so it was the same appointment with the gingivitis in place, sorry. I reconstructed the thick anterior teeth from the palatal side. not beautiful anatomically formed because it has to be a little bit bulky, and then 6 composite veneers on the buccal side, and then the patient went home with a localized increase of vertical dimension of its anterior teeth. And then after 2 months, interestingly, to see that the gingivitis was gone. There was no surgical adaptation. I just pushed the gingiva a little bit away with the matrix. And after 2 months, everything was okay. The bite was reconstructed again. And so I only needed to reconstruct 6 teeth. And also another patient, localized wear. Of course, there's some wear on the molars, but not pathological. So I decided only to do the palatal side where you clearly can see the in-bite of the lower teeth into the upper teeth. Whoops, nope. Yes. So I decided just to reconstruct the upper teeth, do the same as I just showed you with a palatal dowel appliance with composite, direct composite, free out of hand. No buccal veneers, just I straightened a little bit the anterior the teeth to make them more beautiful. After the treatment, there was an opening of the bite, logic. After 2 months, on the left side, it was almost recovered. On the left side, was the right side, it was still a little bit open. After 1 year, the left side was okay, the right side not fully. So, yeah, I will see him in a couple of months, and then also the right side will be okay. So a clear example of localized, pragmatic, and personalized what we are doing. So I'm not going to make a full, because if I'm going to make here 24 restorations, then all the 24 restorations can break down. And now there are only 6 restorations which can break. If you don't make a restoration, they cannot break. Dowel appliance on the posterior. And perhaps this is something where you get nervous if you see it, but then think about this image. Here's your comfort zone, and here is where the magic happens. So that's what I would like to show you. Is this not my idea? It's also from London. So from Subir Banerjee and Shamir Mehta for the group of Brian Miller, they published many years ago, 2014, a multi-centered clinical audit to prescribe an efficacy of direct supracoronal splinting in patients with a cracked tooth syndrome. Okay, what is it? Here are examples from the publication. This tooth, the 7, has a quite relatively small amalgam restoration. The tooth was sensitive and cold and biting, so the diagnosis was cracked tooth syndrome, an incomplete fracture. They removed the amalgam, placed just on top of it, without preparing, 1.5 millimeter of composite as temporary supracoronal splinting. And then the patient went home on 1 contact, fully open bite. Then you would imagine, how is it possible? But the patients were out of pain immediately afterwards. Then, after 2 months, 2 or 3 months, patients came back. The tooth was like, just intruded by the occlusal forces. The bite was okay again, it was closed. So here it was open, and after 2 months it was just closed. 151 restorations placed, 20 teeth failed due to endodontic treatment, extraction, or whatsoever. That's normal with cracked tooth syndrome. And then after the treatment, the top layer is removed, the temporary layer. Then an indirect restoration was placed, so minimal invasive. And we saw this publication from they are totally crazy in UK. How is it possible? But then we read it another time and said, this is genius. This is beautiful. So if they do it with cracked tooth syndrome, we will do it with tooth wear patients. In my own dental practice, I've now treated 70 patients with these kind of treatments. So it's not rocket science, it's just clinical data from my dental practice. This is a girl, and she complained on sensitivity on those 2 teeth. Yeah, then you can say, okay, just take the burr, take a little bit out, place composite, and it's finished. Okay, that would also be an option. But knowing the publication of Subir, I would say, can I do it just without burr, just adhesive? So I placed composite on those 2 teeth. No preparation. The patient went home with open bite, and she came back with the periodontal recall, so that was 6 months, but she told me after a couple of 2 months, 3 months, the bite was closed again. And yeah, it's mostly an intrusion component in these patients. The longer it takes, perhaps also an extrusion component could be present, but that's not fully clear. I don't know. That's the honest answer. Another patient that was more tricky, she complained about pain on this tooth. And there was also a horizontal open bite. She is orthodontist, so she knows how it works. I told her about the procedure. She agreed, but I told her what will happen with your open bite because the tongue interposition. So yeah, okay, that was shared decision making. And after treatment, I put here the glass ionomer, excuse me, the composite on top of the restoration, which tooth, which was painful. And the other side, we placed glass ionomer because there was no problem in the tooth on that tooth. And knowing that glass ionomer will wear down over time, so okay, just try place composite and glass ionomer, and then we'll see what happens, because then you have a bilateral, more stable occlusion. After 2 months, and after 2 months again, the bite was already closed again. The open bite, in the anterior open bite, was in horizontal as well as vertical dimension, similar to what was at intake. And after 12 months, she came back and it was still stable, and there was no change. What was interesting is the occlusal surfaces. So I told you on the 3-7 there's composite, the 4-7 there's glass ionomer. After 2 months, both restorations were still present, and after 12 months, the composite was still present and the glass ionomer was gone. That was also the purpose, but it also happened. But the bite also on the tooth 4-7 reestablished and was okay. So this is really, and you know the patient in your dental practice with the 7th totally worn down. Why should I do all the teeth? Yeah, there's not need to. So perhaps think about this one. It's a really interesting one, but please prepare the patient and say it's a 1 week. It's just strange. It's not feeling really good. No pain, but just irritations for 1 week due to eating and biting and everything. So you have to explain the patient, and if they know that it will be a little bit irritating, then they will accept. If you look at generalized tooth wear, then so it's a full reconstruction because all teeth are affected, and if all teeth are affected, I'm not going to place a dowel appliance, because then after the extrusion and the intrusion, I lost the vertical dimension. So I need space for my restorations. And if all teeth are have tooth wear, then also would like to treat all teeth. This is a patient due to reflux, but okay, we decided to reconstruct the patients. And what we are doing, but that's just Nijmegen stuff, we are doing the DSO technique, direct shaping by occlusion, meaning that it's freehand. We have a mock-up, we know where we're going to, so there's much more in advance of this slide, but it's more or less freehand with a clear goal, with also the amount of vertical increase of the occlusion, and everything you see is just direct composite. And then immediately after the treatment, all restorations and all teeth are placed with direct composite, and after 5 years, even almost 6 years, of course you see some wear facets, some grinding, and some wear and some discoloration here with the tooth 1-1, but the patient was didn't care. I would like to change it for him, but he didn't want to. And also a patient from my own dental practice. This is more mechanical, as you can see, treated fully with direct composite, a little bit similar to what I just showed you. After 6.5 years, and this patient has a night guard each night, the other patient does not have a night guard. And after 6.5 years, you can see that composites, they have a tough life. But after 10 years, and that was a couple of weeks ago, it's still in. Of course, this won't last for many years because the composites are almost through. And I think the goal of the treatment is not to preserve your restorations as long as possible, but to preserve the underlying tooth structure. So at the time, there's no protection anymore. then perhaps we have to do something else. But the main goal of the restorations is to protect the underlying tooth structure. So therefore, I don't want to make crowns or everything else, because then you drill even more tooth material away, and that's not what I would like to see. We also have a randomized clinical trial where we have an indirect composite, is Estenia, and we place then Estenia on the first molars as well as the palatal side of the upper jaw, and the remaining teeth are then restored with direct composite. So this patient, the Estenia restoration is indirect, made by the dental technician, and the remaining teeth are then reconstructed with composite. However, after 2 years, you can see that clear things breaking down. So unfortunately, this is not really working, but I will show you the results in a second. Indirect composites, it's the main conclusion is it's just innovating, it's appealing, the patient loves it, we love it, and the philosophy has to be similar, minimal invasive. This is the baseline. Then we have the preparation and the bite registration. And here it seems that it is almost a full crown preparation, the edges. But if you look at the scan, it's just rounding of the edges. But on the scan, everything looks much more contrast. So this is the preparation, some small seats. It doesn't, there are not huge pits. It's just a small one to have a better seat place for the placement. We have the direct composite mock-up. We have a jig using also a construction on the lower incisor edge. Then this is the bite, which is then scanned. You can see it here. The mock-up is scanned, and the mock-up is then, together with the amount of increase of vertical dimension of occlusion, sent to the dental lab. The dental lab is then making, based on our mock-up, this is the mock-up, and then the wax-up will be made. And after the wax-up, the restorations will be milled. This is, in this case, Lava Ultimate, so it is a kind of composite, indirect composite. However, this procedure can also be used with Emax or Enamic or what kind of other types. So it's minimal invasive, direct, indirect, in this case also indirect. Next slide. Yes, we are using 2 different rounds because it's not possible to do everything in 1 round. And looking, for example, here in this lower jaw, you have the under lower teeth. Then we don't place a tabletop on this and 4. We place the 5. We leave the 6 out and place the 7. And then after placement of this, and we do it because if you place, for example, the canine, perhaps a little bit of cement is then on the 4, and then error on error will occur. So in this situation, it's easy to place the 5, it's easy to play the 7 without interference of the interproximal contact. Then we make a new scan. In the second round, the remaining 6 or 8 restorations are then placed. So clinical slides, this is the same patient. So we have the scanning. Then the tabletops are milled, placed on the rubber dam, preferably. And then in our situation, we make direct composite restorations on top of it. But you also can choose for porcelain, depending on the amount of money which can be spent. And then you have the 1 year, the after, and the 3-year data. And yes, it's looking still fine. The stained fissures are gone after 3 years. So I don't know where they did it in the beginning, but that's not a huge problem. Some data on survival, looking at full mouth reconstruction with direct composite, as I showed you, is a subgroup, 34 patients. Mean age is young, 35 years old, 1,300 restorations included, up to 5.5 years. And overall, depending on the failure type, so including all chippings and huge failures, combining everything, we are approximately 2 to 3% annual failure rate. And I think that's even better than honestly I thought it would be. And this is published last year by Shamir Mehta. You will know him from the UK. And so this is a beautiful publication. Looking at those indirect restorations, so from Estenia, it was a randomized clinical trial, and I will show you the data only on the 6, so the remaining teeth, it's now too complicated to explain. Just looking at the molars, this was published by Luc Klins, one of my PhD students in Nijmegen. And the molars, an annual failure rate of 5.4, and it's a little bit higher than the 2.3 that I just showed you, but that was an overall annual failure rate of all the teeth. This is just the molar. So over 3 years, a beautiful outcome. However, the Asthenia had an annual failure rate of 15.5. It's the odds ratio was almost 4 times higher than direct. So this was a technique which is not really suitable. Looking at the CAD-CAM, so the technique which I just showed you, is now accepted in Journal of Adhesive Dentistry. Yes, of course, you see failures. Yes, of course, we see some chippings and fractures. And up to 5 years now, but stop at, let's say, 4 years, still we have an overall view on failures. It's, yeah, let's say it is 3%, 2-3% annual failure rate. So similar to what I just showed you. This is, for example, after 6, 7 years old, LAV ultimate patient coming back with a fracture or dislodgement. I could replace it, and the restoration has failed from statistical point of view, but still functioning. And then the final question is high failure due to high risk. This is, for example, a patient with a real chemical high risk. So what I showed you in the beginning, a lot of wear on non-occlusal surfaces, waste restoration. So the profile of this patient is more chemical than mechanical, more, not only. And after 3 years, based on the 3D scans, yeah, you can hardly see any differences over time. All those patients, they do not have a night guard, and yeah, there's almost no change. So let's say chemical risks are, for composite point of view, better than mechanical. This patient, a huge amount of reflux, high chemical risk, huge amount of wear, and over time, 1 year in this case, the restorations are functioning quite well. But it was a very interesting finding, and that was not the goal of the project, but it was just what I saw. This is the baseline. Then teeth are reconstructed, and after 1 year, you can see that the restoration is still functioning, but the tooth beneath the restoration is destroyed. And if you do a 3D subtraction, you clearly can see that there was some attrition on the top and then a huge amount of wear on the lingual side. And there was 300 microns lost in 1 year. From whoa. So the high chemical risk is, yes, affecting the tooth. Then mechanical risks, so more, is a totally different view. You see clear facets here. Things are breaking down over time. Yeah, and after 3 years, restorations are lost, teeth are lost. So where is this patient going to? The patient knows what's up, and if you would make crowns or eNamic or Emacs, he will destroy everything. The final one is this one, where at baseline, and he was reconstructed, and after 1 year it was quite okay, but you could already see that the composite was really challenged, initial caries. After 3 years he came back and said, hey boss, there's a piece broken off and here's some caries. Okay, so I repaired this one, and then after the repair, okay, everything was okay. 1 month afterwards he came back again, boss, what you did, it didn't help, it's broken again. So for the second time I repaired it, and then after 5 years, 2 years later, he came back and then the tooth was gone, or the teeth had problems. And then making this presentation, I just saw something very interesting, that even at the beginning, the whole start of the project, there was already a crack formation. There was an endodontic treatment in. So this tooth was just crack, vertical fracture already 5 years ago, but now it happened. Yeah, and these patients, they destroy everything. And you know these patients from your own dental practice. You can say to them, don't do it, but they will stay grinding, clenching, whatsoever. So it will be a repair. It will be something else, prevention, but still a high risk is high failure. So the conclusions are: priority should be given to the diagnosis of the etiology, of the wear, of course, and instigating appropriate preventive measures, what I tried to tell you. Patient with severe tooth wear, but without functional or aesthetical complaints, should be monitored to get and to learn the patient better. And not every severe tooth rot patient needs a required restorative treatment. That's what I tried to tell you. And restorative treatment should be as conservative as possible, employing minimal invasive techniques according to the dynamic treatment concept. Meaning, think about the first restorative treatment, but please also think about the next upcoming treatment steps, because these patients are young and they need to keep their teeth alive during the rest of their life. This is not what I do myself. This is the whole group which is linked to our project in Nijmegen. You can see quite some London-based names, and so this is the people which are linked to the whole project. I'm really proud of all these people, because this was also the reason why I could give this presentation. So I think there will be some questions, and thank you very much for listening, and I'm really looking forward to your questions.
So Bas, thank you so much. Superb overview of latest thinking, and with an emphasis on both prevention and minimal intervention. It's interesting, I think, if we put the clock back 20 years to see how things have changed over the last 20 years. So thank you for that very thoughtful presentation. Now, I think we've had some questions. Bas, are you happy to take some questions the next 10 minutes or so?
Oh, yes, of course.
So Fatima, I think you're kindly the keeper of the questions.
I am, and we have had some questions come in. Okay, so the first question for you is, with the DAL buildups in post-orthodontic patients, what protocol are you using for wear of retainers?
The last sentence I could, what protocol?
Sorry. With the DAL buildups in
Yeah.
post-orthodontic patients, what protocols are you using for wear of retainers?
Okay, that's a good one. This patient, so normally I wouldn't do it in really combination with orthodontics, because the orthodontic patients, they need some retainers. This was in collaboration with the orthodontist. He said, okay, at this moment it's okay to do it like this, and after everything's settled, we can do something. But I really understand if it's a patient coming out of the orthodontics, we really have to discuss with the orthodontist, because in the meantime you cannot give the patient a retainer, because that is disturbing the dowel effect. So it was a very interesting case. I think it's a good point also to take into account when giving this presentation again. But I think it's the majority of patients is without orthodontics, so it's just a dowel, and there's no discussion of there has to be retainers or so at this moment. Yeah, okay. Good point.
Okay, thank you. Another question that's come in: when increasing the OVD in DAL or a full mouth recon, are you working to the terminal hinge axis or just an arbitrary jaw relationship?
Oh, it's a very beautiful name. I won't repeat it. You have 2 points. One is the VDO increase. What I'm not really going into detail, not for you, but just in the treatment on how the condylus is positioned, etc. What we are aiming for is a centroculation, and the teeth are built up that much that it is strong enough. Don't make it too thin. Don't be scared of making it a little bit more bulky, what I showed you, because if it's too thin, it will break, especially in these patients. And the amount of VDO, also Shamir Mehta published about that, but I couldn't show you today. The amount of, the thicker the restorations, the more protective they are. And the amount of VDO, you can really play with it. There's absolutely no problem. There's no necessity to test a VDO in advance. These are non-TMG patients, so no craniomandibular disorder patients. And also with the dowel, it's anatomically correction. And when you have the dowel, as I showed you, it's like a guidance plane, and the patient is put back a little bit. So if there would be a kind of a interference in the occlusion due to the dowel, as it is the palatal side will push the lower jaw in the central oculation. So we are not really aiming for it, but due to the technique we are using, it will happen in the end.
Brilliant. Okay, thank you. Another question. When would you choose ceramic onlays for posterior molars compared to indirect composite and also direct composite?
Good one. The price. Honestly, in the higher the risk, going back to the title, the higher the risk of the patient, the less positive I'm to use more complex techniques like ceramics or whatsoever, because knowing that these patients are at high risk, they will break down everything. They will break down an Emax, they break down everything. If they break it down, then I think it's for the patient also preferable that it is composite because it's easier repairable. But again, in a normal patient where you think, okay, you can use everything, yeah, ask me and I would use a composite. If ask somebody else, they can use an Emax. I don't think there is a real good argument to say yes or no. The only thing is, the higher the risk, be careful with applying more expensive, complex procedures. Don't think that the indirect restoration, it will be much stronger. They will break and composite will wear. And in the end, also the financial situation is very important. So indication is much more important than the final technique. And if you're really into Emax and you can do everything with it, still be careful with these kind of patients.
Okay, thank you. I've just got a question in from Alex Milosevic. The cases are all young with full arches. Will survival differ in older patients with missing teeth?
Good question. Hello, colleague Milosevic. I don't know. Honestly, I think yes, because I showed you beautiful cases with beautiful arches. Yeah, younger patients, quite young are they in the whole project. The less if you have less teeth, then also the forces on those restorations which are still remaining, or the teeth which still remaining, would logically be higher. The question is also, why are these teeth lost? Because sometimes patients are that aggressive in biting that they just destroy sound teeth. So is it due to caries or is it really due to extreme bruxism? So that will be one of the topics. So if it's really due to caries and periodontal problems, then I don't think that the restorations are at a higher risk due to fracture. But in patients where they're really destroyers, as we call them, I think your restorations, yeah, they won't last that long. But okay, save the tooth beneath it.
Okay.
Point.
Okay, thank you. Another question just coming from Ursula Jogeza. Which tooth wear cases do you choose for indirect restorations like full crowns?
Full crowns, never. I think it's obsolete to use. Sorry to say that in the UK, but still, you asked me to give a presentation, so I just say it. I think full crowns in these patients are obsolete. You even remove more tooth material than the patient already destroyed by himself, because it's mostly men. So if you're going for indirect, use minimal invasive technique as I showed you. Yeah, and which kind of cases? Yeah, it's difficult to really to say it in one sentence, but again, the higher the risk, be more reluctant with more complex techniques. But crowns, no, I wouldn't make it. Even only if there's already a crown present and we are going to do a new crown, that's a good place for a crown.
Okay, thank you. Ursula, thanks you for answering her questions. I've got another question from Ahmed Al-Habashi. What's the main risk? Should we worry about? What's the main risk? Should we worry about on treating these cases? So he wants them to know the main risk in treating these types of cases.
Sorry, say that again. What's the main risk of?
Yeah, what's the main risk in treating these types of cases?
The main failure risk is fracture. That's the also logic, and that's what we see in the indirect composite restoration. That's what we see in the direct composite restorations. Of course, if the dental hygiene is really bad, caries can occur, but fracture is of course a very important one in these patients, and that's with the indirect as well as the direct. I also have to say, also looking at the question here before about crowns and Emax, there on crowns, there's no clinical study available on tooth wear, so we think it's the gold standard, but there's no gold standard because there's no publication on it, no survival publication. Of course, case reports, but I'm not really counting them. And on Emacs, there are only several publications from the group from Edelhoff, from Munich, but that does not, the publications which are now there, 13-year or 11-year-old, 11-year survival. It's a beautiful outcome they have, but it is not minimal invasive. It is less invasive than compared to crowns. But I think honestly that using Emacs or Inamic or composite, the outcome in survival will not differ that much.
Okay, thank you. I'll take one last question because it is related to the previous question. It's from Dana Al-Radan. What about cases with palatal erosion? Still no crowns?
Still?
Yeah, so they're sort of saying if you have a case with palatal erosion, would you still advise no crowns? You know.
Yeah, why not? I don't know exactly the case, but yeah, I would really rely on the adhesion, on minimal invasive. And yes, I know that many people will think a little bit different out of it, but okay, we have to also have a goal in research where we would like to go to. And I think that traditional crowns, full prep, especially in these patients, they are very young, they have to survive their teeth. And again, the goal is to save the remaining tooth material which is left. And I don't think that then placing a crown, and perhaps a crown will stay a little bit longer, but in the end, the crown will also fail. Perhaps it will stay 20 years, perhaps 25 years, but then the patient is perhaps in the 60s. And then we also need a new round. And then I would say survive the tooth material, which is there. And therefore, I would not go for crowns in a younger. And if the patient is old and it's the last resort, and okay, if we now do it, it will survive for 15 years. And then the patient is, let's say, in the end of his life. Yes, I won't say that you are doing a bad job, but looking at 35-year-old patients or 40 years old or whatsoever, I don't think it's wise to really make a full preparation on old teeth. It's too risky.
Okay, thank you. I am going to have to stop it there because we're out of time. So just to say thank you from us, and this recording will be available on the RCS website. So back to you, Andrew.
So thank you, Fatima. Just literally a couple of points to close. So thank you, Fatima, and all the team for organising. The faculty is planning to run an extended toothwear course, so more about this and also more about the monthly webinars in due course and on the website. And just finally, Baz, to you, it's been a real pleasure to work with you over the last year or two on the BDJ toothwear book, which hopefully we'll hold in our hands shortly. And now this over the last few weeks, few months. So I know just how busy you must be. So we are incredibly grateful for your time. I would normally at this point perhaps hand you something by way of thanks, but we can't at the moment. So hopefully when you come over to the UK, we can get together. But thank you. I'm sure everybody in the call has benefited from joining this evening. So Baz, a real big thank you from all of us.
Yeah, thank you for inviting me. It's a real pleasure.
Thank you all, and have a good evening.
Thank you.